So I want to thank everybody for coming today, and I particularly want to thank Marla for the introduction, and Marla, Teresa, Megan, and Sarah for putting together this excellent, I believe, second annual Women's Health event. The first was a really big success, and I think that today's is going to be as well. What I'm here to do today is talk about neurologic disease in women and introduce you to our Women's Neurology Clinic here. I'm an epileptologist, and I run a program for women with epilepsy, so you'll see that that is somewhat of the slant in my talks. But this afternoon, you'll also have the opportunity to talk to Dr. Atarian and Dr. Curran, who are experts in sleep, migraine, and stroke, and they'll have an opportunity to expand on some of these things. What I really want to do today is give you an overview of different things that are important to women within neurologic disease and the intersection between female hormones and reproductive health and neurologic disease. I have no disclosures relevant to this talk. I have some researcher support from UCB and from Sage Pharmaceuticals. So again, to highlight the intersection, there's so many ways that sex-based clinical care and sex-based research intersects with neurology. I won't be able to cover them all today, but what I'm going to be talking about are three particular ways that they intersect, and largely showing you how they play out in sleep, in migraine, sleep, and epilepsy. So the first is that female sex hormones affect the timing and severity of neurologic symptoms. The second is that some neurological medications can interact with hormonal contraception, which is an issue I'm particularly interested in. And three, neurological conditions and their treatments have special implications for pregnancy. So I'm going to start with a case to give you an idea of a consultation that we may see in our Women's Neurology Clinic. This is a 45-year-old woman who comes to see you in your office for assessment of migraines. She has had common migraines without aura since puberty. They typically occur 1 to 2 days before her period. Her headaches have become more frequent and severe in the last 3 years, which corresponds to the beginning of menopausal symptoms and less predictable periods. And so she might ask you, will her headaches continue to be severe when she completes menopause? Would you say likely no? How many hands for that? Okay, quite a few. Likely yes. Also a couple of people, and no way to predict. Okay, so it's about sort of an even split there. So although every individual is different and you can never give a guarantee, research suggests that when a patient completes menopause, if her migraines, particularly if her migraines were hormonally sensitive, they may likely improve, and I'll show you the evidence to suggest that. Migraine is, it's important to establish, migraine is much more common in women than in men. It's really a problem that plagues women. The 1-year incidence of migraine is 17% in women and 6% in men. Lifetime prevalence is 43% in women and 18% in men. And we know that hormones play a role in this, female hormones play a role in this. One of the lines of evidence to suggest that is the female to male ratio increases significantly at puberty. So, I'm going to start with some definitions of migraines that seem to be associated with female hormones. And one is menstrual-related migraine, which is the most common thing that female patients with migraine complain of. These are migraines that regularly occur 2 days before to 3 days after the menstrual period, but the migraines can also occur at other times during the month, and certainly with other triggers such as sleep deprivation or stress. This is reported by 60% of women with migraine, so it's very common. There's also an entity known as pure menstrual migraine. These are patients who have migraines that only occur 2 days before to 3 days after the menstrual period, and really not at any other time in the month. This is less common, but still reported by 7 to 10% of women with migraine. So the majority of women who suffer from migraine do notice a fluctuation with their menstrual period. And what's the reason for that? Well, most lines of evidence have suggested that the reason for the increased frequency of migraines right before the menstrual period is due to the withdrawal of estrogen that happens at this time. This is a graph of the menstrual cycle. You can see here, this is the beginning of the cycle to a typical 28-day cycle here. And there's really one line I want you to pay attention to here. This is the dark blue estrogen that represents estrogen here, which typically falls before bleeding. And the gray here is the incidence of migraine throughout the month. So there's a little peak around ovulation, there's a much bigger peak before the menstrual period. And again, there's this fall of estrogen at this time. There's also a fall in progesterone represented by the pink line here. And what people did to try to figure this out is that they gave women with menstrual migraine or menstrually related migraine, they gave them, one group, they gave estrogen at the end of the menstrual period, at the time of the cycle, at the end of the cycle before the menstrual period began. And if you give estrogen, that prevents the headache that typically occurs, but it doesn't stop the bleeding. If you were to give women progesterone at that time, that stops the bleeding, but it doesn't stop the headache, which is what led to the conclusion that it's really the withdrawal of estrogen that seems to trigger this migraine around the time of menses. So the sensitivity to hormones affects women at other times in their life cycle as well. So if we look at pregnancy, for example, it seems that pregnancy is in general a relatively protective time for patients with migraine. Certainly there are migraine sufferers who have headaches during pregnancy, but the majority will experience some relief of typical migraines during pregnancy. What you can see here, this is weeks of pregnancy, where estrogen and progesterone, estrogen was chiefly important here, is rising, and the migraine incidence stays quite low. Where the migraine incidence peaks, as you might imagine, is a couple of weeks before delivery and into the postpartum period, represented by this sort of mountainous thing here, as again the estrogen is falling at that time. So that's another important thing that helps you counsel women on trying to minimize the use of either prophylactic drugs or other drugs for migraine during pregnancy. Back to the patient that we talked about in the beginning who wants to know why our headaches are worse now as she's entering menopause and what's her long-term trajectory. Is this just going to continue to be worse? Well, most data suggests that no. We know that perimenopause, the time that people start experiencing menopausal symptoms and start having irregular periods, is a period of a lot of volatility of female hormones. So there's a lot of volatility of estrogen during this time, and that seems to trigger an increase in the frequency of migraines. And you can see that represented here between age like 35, peaking around age early 40s. But then as estrogen levels return to very, very low, as people clear menopause, get to the other side of it, it seems that migraines really improve in women, and that's one silver lining to going through all this. How do we treat sex hormones? How do we treat migraine, and particularly hormone-sensitive migraine? Well, again, I don't treat migraine. This is really the expertise of my colleagues, Dr. Kern and Dr. Rosenthal, who are part of our group, and Dr. Kern will be here this afternoon. But I'll just give you a little flavor for it. For patients who predominantly have 1 or 2 migraines a month right before the menstrual period, we typically start with just abortive therapies. These are things like NSAIDs, ibuprofen, or triptans. If it's really predictable that this headache will occur at this time of the month, sometimes people recommend giving these medications prophylactically just around the time that the period is expected, so maybe 3 days before, starting on 3 times a day ibuprofen. If patients have frequent headaches throughout the month, or really disabling perimenstrual migraines that don't respond to other treatments, then patients can be used prophylactic therapy. So those are typical therapies we use for any migraines: beta blockers, calcium channel blockers, topiramate, or tricyclics. But again, important to keep in mind if you're dealing with a woman of reproductive age that these are medications that ideally we would not want somebody to be on when they got pregnant. So you want to recommend that before they try to get pregnant, they come off of it, and that while they're on them, they're using an effective form of contraception, which I'll talk about a little bit later. Topiramate in particular is widely prescribed for migraine in women, but has been considered in the epilepsy world is increasingly associated with adverse outcomes of pregnancies and also can be associated with contraceptive failure, so that's an important thing to keep in mind. If the above treatments fail, sometimes people recommend actually hormonal treatments, such as continuous cycling combined oral contraceptive pills to avoid the menstrual period altogether, or perimenstrual estrogen. But there's a big caveat to that a lot of people ask me about, which is, what is the risk of taking contraception in a woman, or hormonal contraception in a woman who has migraine? And this is a very controversial issue. because there seems to be an increased risk of stroke, at least in women who have migraine with aura, and there's also an increased risk of stroke in women who take birth control pills. And those two things seem to be at least additive in terms of risk factors. So many clinicians in some groups take the standpoint that any woman who's got a migraine with aura should not be taking birth control pills. That's not always true, and again, people who are experts in this really weigh the risks and the benefits, but one thing I will say is that if you're a clinician treating somebody with migraine with aura and you recommend birth control pills, you need to really safely counsel them. So if you look at the different groups and how they have strategized their or stratified their recommendations, this is the American College of Obstetrics and Gynecology, and what they recommend is for patients who have migraine with aura, they should avoid combined oral contraceptive pills. The World Health Organization says the same thing, but the International Headache Society says, well, you know, it depends. You have to kind of look at the individual and do a risk-benefit assessment, but you do have to counsel them. In patients who are younger, in patients who don't have aura and who are younger, these two groups, the Obstetrics and Gynecology and the World Health Organization, say that combined oral contraceptive pills are probably okay. But if their age is over 35, they still recommend avoiding it because that's an additional risk factor for stroke. And pretty much all three groups agree that if this individual smokes and has migraine, with or without aura, they really shouldn't be prescribed combined oral contraceptive pills, or they must stop smoking first at least. And if we want to look at what this data is based on, research had suggested that combined oral contraceptive pills alone, even without a history of migraine, increase the risk of stroke 2.7-fold, migraine alone 3.6-fold, and if you are taking birth control pills and have a history of migraine, your risk of stroke is 7.2-fold greater than the general population. It is important to keep in mind, however, that the risk of stroke in this group at women of reproductive age is quite low. So we're talking about 5 to 11 per 100,000. So even when you have an increased risk several-fold, it's still a small number, but something that an individual patient should be counseled about. There is maybe some further stratification that's still being worked out. That high-dose birth control pills, which is really what was studied in the early studies about this, seem to be the largest risk factor, and it's not clear that low-dose birth control pills, which are very common in the market today, carry the same risk, but that's something that's still controversial and being worked out. As I mentioned before, it's really the migraine with aura that seems to be the risk factor for stroke, and some studies have suggested that migraine without aura did not increase that risk. I encourage you to go to the afternoon session and talk to Dr. Curran some more about these very important issues and when it is appropriate to prescribe those medications. So to shift gears and talk about my next case, this is a 32-year-old woman with narcolepsy who is seen for contraceptive counseling. She takes modafinil 400 milligrams. Modafinil is a medication that we use for narcolepsy. It's also a medication commonly used for fatigue and multiple sclerosis, for example. And so she's taking it for excessive daytime drowsiness associated with narcolepsy. And she's interested in her contraceptive options. So which of the following are appropriate contraceptive options for this patient? 1A, the estrogen patch, B, the progesterone pill, only pill, and C, combined oral contraceptives, or D, an IUD. And yes, so an IUD would be the favored option for her. As is the case with many of our patients in the neurology clinic and many patients with neurological conditions, they may be taking medications chronically that are not ideal for pregnancy. I'll get into that in a little bit. So for these patients, we want to be sure that they're using effective contraception while they're taking this drug, because as we know, many pregnancies are unplanned. But one thing that is often under-recognized is that many of the medications we use to treat neurological conditions, modafinil and armodafinil, for example, are potent liver enzyme inducers, and thus they can increase the clearance of ethinyl estradiol and likely progestins as well. So patients taking these medications should be advised to use alternate or additional means of contraception, because the hormonal contraception often will not work or not be as effective as it should be. This also affects me a lot as an epileptologist, because About half or over half the medications that we prescribe in epilepsy are enzyme-inducing anti-epileptic drugs, and all of the drugs on this list potentially can make oral contraceptives less effective. So you really don't want patients taking these drugs, also taking oral contraceptive and not being advised that this is not the most efficacious contraception for them. When we talk about the type of hormonal birth control that's affected by these, combined oral contraceptive pills would be affected by these enzyme-inducing drugs, progesterone-only pills, vaginal ring, a birth control patch. Nexplanon is somewhat controversial. Nexplanon is a progestin insert. Whether or not that has enough progesterone in it to avoid the enzyme induction effect. But pregnancies have been reported with patients on these enzyme-inducing drugs using the progestin implant. Plan B, patients should also be counseled that they would probably need a higher dose of Plan B if they are on these enzyme-inducing drugs. The WHO and the CDC do state that Depo-Provera probably has a high enough dose to get around the enzyme-inducing effects of the anti-epileptic drugs that are enzyme inducers. In our practice, we often give more frequent injections of Depo-Provera or a higher dose to try to trump this effect. Condoms are effective, but as we know, condoms are not nearly as effective as an IUD, or rather I should say condoms are not affected by these medications, but they're not nearly as effective as the IUD. And I want to also mention that the IUD, which I think most of you know, is a copper or a plastic insert which is put inside the uterus and can prevent implantation, used to be only prescribed for women who had had children, but is now considered by the American Academy of Pediatrics to be the contraceptive of choice, or one of the contraceptives of choice, along with other long-acting reversible contraceptives for even teenage girls. So the IUD is probably underutilized and should be utilized more. And I do want to comment that even the IUD that has progesterone in it, because that progesterone is predominantly a local effect, is still acceptable for patients who are taking enzyme-inducing drugs. It's also important in our field to think about the effect that hormonal containing contraception can have on the medications that we prescribe, as well as the other way around. So this is a letter from a patient who introduced herself to me. She's a patient who had generalized epilepsy that started when she was 17. It took her a while to get her seizures under control with lamotrigine. Once the lamotrigine was at a appropriate level, she stopped having seizures and she went to college and she was doing really well. And then when she started birth control pills for contraception, she had 3 seizures in a very short period of time. And she found that obviously really disturbing. It really offsets your lifestyle when you're just becoming a young woman and you're in college and you no longer can drive and your school schedule is thrown off. She went to both her OBGYN and her neurologist and asked whether the birth control pills could have been responsible for this. And was told that no, it probably was not related. She then found something that I had done online and a similar kind of talk as I'm giving here, and realized that yes, actually the birth control pills did affect her seizures because they affected the lamotrigine. And the estrogen in birth control pills has an enzyme-inducing effect. It induces the glucuronidation, which is one of the key clearance pathways for lamotrigine, so effectively can cut levels in half, and thereby if you decrease somebody's level, in her case it went from like 9 to 6, that can cause somebody to be more susceptible to seizures. So this is something we can work around, but patients need to know about it, and physicians like yourselves really need to know about it, because the patients may not hear about it from the neurologist, so they may need to hear about it from family practice or from OBGYNs. This is some work that we've been doing in our group because it is my passion that I think to kind of convey to my colleagues and to everybody out there, that I do think it's the neurologist's responsibility, as well as OBGYNs and family practice, to counsel patients about appropriate forms of contraception, particularly if they're using drugs that could affect a pregnancy. So what we did is we looked at our group and our counseling rates, and we split the clinic notes on our large group of patients into patients who received no counseling about contraception, those patients who received sort of general counseling like you know, your medications might affect your birth control, you should think about it, and patients who actually had counseling that involved the word IUD, where they were introduced or reminded of the concept of an IUD. And you can see that if the physician spoke to their doctor, if the neurologist spoke to their patients about an IUD, those patients were much more likely to switch to an IUD, which is represented by the blue bars here. So we have taken the position that actually neurologists can play a role in contraceptive choice of their patients and should take that role, and we're instituting things to make this more common practice at Northwestern. I'm going to end with a case about pregnancy, which is really what my specialty and what I spend most of my time doing is counseling young women about future or current pregnancies and how we can optimize them in terms of risk of seizures and risks of medications. So in this case, a 32-year-old woman has JME. She's well controlled on valproic acid. She's never tried another seizure medication, and she's recently married and wants to get pregnant in the next year. So what would you recommend to her? Do you recommend that she A, stop the valproic acid and go without any seizure medication? B, that she would change to levetiracetam? C, that she would change to oxcarbazepine? Or D, that she would change to topiramate? And because I'm kind of running short on time, I'll tell you now that what I would do is I would recommend that she try to switch to levetiracetam. And what I want to just briefly touch on is that what we try to achieve with patients who have epilepsy, and most patients with epilepsy need to stay on chronic medications, is a balance between the risk of seizures and the risk of medications. It's important to tell patients, as I do, that the majority of women with epilepsy will have normal, healthy babies. What they are at somewhat increased risk for, depending on the medication that they take, is major congenital malformations, which are defined as fetal malformations which affect physiologic function or require surgery. These are the best studied outcomes to date, and the risk in everyone taking even if they're not taking any medications, the risk in the general population is between 1% and 3%. These are some examples of what major congenital malformations are. You guys are probably aware. These include spina bifida, heart defects, cleft lip and cleft palate, and hypospadias. These are some of the most common congenital malformations that have been evaluated in studies of anti-epileptic drugs. This is a really busy slide that I use for my own knowledge, which just looks at several pregnancy registries, international pregnancy registries that have looked prospectively at women taking seizure medications during pregnancy. And this is not a slide that I expect most people to internalize or study, but this is just to show you what I do to kind of make my recommendations to patients. And I try to incorporate all that data across many different registries because it starts to tell a story when you look at many different registries and you see the same numbers. And so what I explain to patients when we're choosing a seizure medication for a woman is that we have, for some drugs, we have a lot of information about them, and some of them we don't have much information at all. So I try to create kind of this 3D graph, which I show them. And on the y-axis here, we have the relative risk. On the x-axis here, we have the amount of information available to us. So there's one drug which is, we have a lot of information, and we know that the relative risk of taking this drug during pregnancy is much higher than any other anti-epileptic drug, and that drug is valproic acid. And there are about 2 to 3 drugs where we have a lot of information, and we're starting to become increasingly comfortable that although the risk may be somewhat higher than the general population, if at all, that it's not very high. And those drugs are carbamazepine, lamotrigine, and levetiracetam. And I'd basically say that the rest of the medications sort of are in this yellow category where we still need more medication, and we kind of can stratify where they are. Particularly, there has been concern for a long time about phenobarbital, and topiramate has been recently made a Class D drug rather than a Class C drug because of an increased risk of cleft lip and cleft palate. I should also mention in regards to valproic acid that exposure to valproic acid during pregnancy has been consistently associated with cognitive issues as well. So there seems to be an average decrease of 10 points of IQ in children exposed to valproic acid during pregnancy compared to other seizure medications and compared to the general population. There also seems to be an increased risk of autism. Other drugs are still being studied and more data is needed. And this is something that we're involved in a important nationwide study here at Northwestern. In terms of planning pregnancy with anti-epileptic drugs, what I do is, I think the most important thing is start early. So that means not when somebody says they want to get pregnant, but when they say that, but when you start your first anti-epileptic drug. So start talking to them about using a drug that would be compatible with pregnancy and about your long-term plan. We also recommend complementing anti-epileptic drugs with folic acid daily in any woman of childbearing age who's taking a seizure medication. We also try to minimize both the dose, but we minimize the dose and the level of the drug if we can. And if possible, we change a patient from one medication with known high teratogenic risk to a lower teratogenic risk drug if we can. And as I mentioned a couple times, we also try to find the patient's ideal drug level. And that's important because that can change drastically during pregnancy. I mentioned to you how estrogen can affect lamotrigine metabolism, for example. We know there are a lot of changes that happen to the body during pregnancy. We know that there's increased fluid volume, increased urine output, but there's also increased drug metabolism. So as one example, estrogen increases drastically as pregnancy, as I showed you before, and estrogen can increase the metabolism of, for example, lamotrigine, as I showed you before on the letter from my patient. And this causes lamotrigine, which is commonly prescribed to women during pregnancy, to be metabolized very rapidly, and often the dose needs to be increased 200 to 300-fold during pregnancy in order to maintain the same levels and the same seizure control. I'll stop here. I'll quickly mention that a lot of women who come to me had told me that when I started my practice, many women told me that they were told that they shouldn't get pregnant taking seizure medications. Then I had a cohort of women who came through and told me that they could get pregnant, but they just couldn't breastfeed, which is really not true. We really encourage breastfeeding for the majority of women with epilepsy, even if they are taking seizure medications. Some seizure medications have been studied more than others, and so we feel safer with those. But I can say that in at least 2 studies now, women taking seizure medications during breastfeeding has either had a neutral effect or even a beneficial effect. So in one study, the group showed that there was no significant difference in IQ babies who were breastfeeding with exposure to phenytoin, valproic acid, lamotrigine, carbamazepine versus those who were not breastfeed. Actually, at the 6-year mark, those babies actually had a slightly higher IQ if they were breastfed than if they were not breastfed. Hence the little graduation cap on this baby. So I will stop by mentioning that we are part of this national study, which is a new study following the children of mothers, a prospective study following the children of mothers who are taking seizure medications during pregnancy. And we're looking at, this is called the MONEED study. The PIs are Kim Metter and Paige Pinnell. And we're looking at obstetrical complications, such as why is there an increased risk of C-section in women with epilepsy? Why is there seems to be an increase of preterm birth, or is there? Looking at seizure frequency during pregnancy, but also looking at the effects of breastfeeding and the neurodevelopmental effects of these drugs on children. We'll be following these children for 6 years, hopefully. So we've been very involved in this trial, and we are still recruiting both pregnant women with epilepsy as well as pregnant women who do not have epilepsy as a control group. So if you have patients in either of those categories who would be interested in participating in a long-term study looking at their children, please let me know. Just to wrap up, this is the Women's Neurology Center, who we are. So the sleep disorders is headed up by Hayar Atarian, who will be in the group this afternoon. Stroke and vascular disease are attended to by Dr. Kern and Dr. Ruff, who are both stroke specialists and interested in women's health. Headache is also Dr. Kern and Dr. Rosenthal, and that is a much younger picture of me. So I will wrap up with that and take questions later. This is my son, and I use this to say that we have come a long way, but we still have a lot longer way to go. Thanks for your attention.